AI can do novel things. It can also help to do better what humans are already doing.
Thank you very much for being here. So when we talk about AI in cancer diagnosis, what is it that AI can help us detect in tumor images that otherwise might be missed?
Thank you, Michaela. So AI is very exciting right now in terms of medical imaging in general, multiple applications, pathology, imaging, the whole spectrum of what is available. For pathology specifically, AI can enable us to see things that pathologists cannot see. So, for example, we are able to recognize mutations, genomic alterations of the tumors that you would not be able to recognize with a human eye. So it can see novel things. Also, it can do a better job of recognizing things that we humans can recognize. For example, MSI high is high TMB are situations where typically you see a lot of immune infiltrates. Pathologists can have a hint that actually there is high likelihood of having a TMB high or MSI high case, but AI can help with that process. And then also can help with things that are routinely done by the human as well. So they can help in being more precise and more accurate in the identification of metastases in lymph node, for example, or a variety of other tasks. So to summarize, AI can do novel things. It can also help to do better what humans are already doing.
Some of your work suggests that you can extract molecular information from imaging data and from tumor tissue images, but how are we close to bringing these to the actual clinical practice?
Yeah, thank you, Michaela. So I feel that there are some niches where this is going to be applicable very, very soon, or is already applicable. So, for example, there's a situation where patients need to have an answer immediately, as soon as possible. I'll give you an example: lung cancer, EGFR mutations. Patients cannot wait for a molecular test. Often the molecular test arrives only after a week or 10 days or 4 days at the best. That waiting time can be clinically a challenge, and so it is possible to use AI for shortening that and have an answer immediately. The answer is a likelihood of a certain mutation. It's never 100%, but that likelihood enables the physician to make a treatment decision, which most of the times would be very helpful. So that's one setting. But there are also other settings where I think this will have clinical applications very, very soon. I think a couple of days ago, there has been the first approval for a foundation model for a breast cancer signature. The company is called AI. They use the foundation models for identifying changes in the image that correlate with outcomes in patients who are who have breast cancer and are ER and PR, hormone receptor positive and node negative. Very similar to what Oncotype DX does. So they got an approval for this by the FDA, and you will see the clinical deployment of this kind of assay in the very near future. And this just happened a couple of days ago. The third example I want to give you is that even now you can use these technologies to screen patients for mutations which are treatable. They're driver mutations, but they're rare in a certain tumor type. So very often those are never tested because they're rare events in the specific tumor type. But you can use the AI to identify those and then get a confirmation through a genomic test. And so it becomes a screening tool for identifying patients who may respond to treatment, who are currently missed because they will never be tested because that alteration is very rare. So a combination of scenarios where I do think you will see clinical applications in the very close future.
But in your work, you also put together data like electronic health records, clinical data, and so on. Why is it important to look at it all together? And what can you do in order to inform therapies or maybe drive treatment decisions?
Yeah, we are super excited about the value of multimodal AI and the integration of different data sources. Specifically, I think biomarkers have been very helpful in general. We use driver mutations for personalized medicine. We use biomarkers like PD-L1 for immune oncology choices, for example. But I think they only capture part of the picture. So the piece that is missing is really the patient component. So everything is really focused on the tumor. but we're basically missing half of the picture, or maybe even more. And we feel that the way to bring that other half into the diagnostic process is going to be that kind of integration that you described. So bringing together genomics, spatial biology, immunohistochemistry, pathology, and radiomics. So the clinical imaging is going to be crucial. We have initial preliminary work in this space showing the value of this. I have personally no doubts that this is going to be the way future for doing better selection of patients for treatment, or better treatment selection for the patients. I guess both scenarios are applicable because you have clinical trials and and then patient selections. But I feel that's the future. There's still challenges, obviously. Data sets are very different. They come from different sources. You need to harmonize them. Often are not easily accessible currently, but I do think that's the future, and look forward to seeing the application of these novel modalities to change the way we treat cancer.
When we think about cancer, we usually think about a mass of cells, but you also look at the environment, like the immune cells or the tissue organization around it. How is AI able to help in understanding this, and what can we actually get out of it?
Yeah, so the tumor immune microenvironment, or the tumor microenvironment is crucial in determining the outcomes. The proof of this is in immuno-oncology. These drugs work on immune cells, and they've been game changers in a variety of tumors like lung cancer, melanoma, curable diseases until a few years ago. Now we have 60% long-term survivors from melanoma, for example. A dramatic change, and that outcome is really driven by the immune microenvironment, or by the tumor microenvironment in general. So we feel that AI will make a big difference there. There's a new generation of technologies which go under the buzzword spatial biology. They produce very rich data. They can be multi-omics kind of data sets, and being able to work on those data sets because they're so rich really requires AI. I almost would make the claim that without AI we will not be able to make progress because we are not able to consume these data sets. The size is so large, and the quantity is, and the complexity is so multidimensional that only AI can really help us make progress there. The other point I want to make is that these technologies that I mentioned before that are really helpful for studying the tumor immune microenvironment, or the tumor microenvironment, are also currently still very expensive and very slow. And so another thing that we can do actually is use AI to simulate the output of these platforms. And so you can train the AI on spatial biology data sets and then match those to more conventional techniques like H&E, hematoxylin pathology stains. They are done routinely in every hospital. They cost a few dollars or a few cents per slide, and then you can leverage that training to make inferences about the tumor immune microenvironment through the use of AI. So two pathways: one is the consumption, and the other also is the generation of synthetic spatial biology kind of data sets to the convoluted tumor immune microenvironment. And no questions in my mind that understanding the relationship between the tumor and the immune microenvironment is going to be essential for the future.
And beyond analyzing tumor images, where do you think that AI will have the biggest impact across cancer research or the clinical practice?
Yeah, so AI is going to transform medicine. I think we are going to be in the golden age of biology. I think one of the bottlenecks we had in the past, we talked about this before, it was really having data sets that are too complex to actually evaluate. I think that dynamic is going to change, and AI is going to help us actually consume those and make sense out of those. But I think there's also a spectrum of applications which really impact clinical care in the daily kind of life. So when physicians meet with a patient, you're going to have AI which helps summarize the findings, will help the clinicians to actually make clinical decisions. I do believe it's going to be transformational across the whole vertical of medical delivery. One example of application is what we call the agentic tumor boards. So, for example, oncology patients are typically discussed by a multidisciplinary kind of team. So you will have radiologists, radiotherapists, oncologists, surgeons, and pathologists meeting together to discuss the patient. You can actually simulate that with agents. And so you have agents which have different roles, and they can actually help in the preparation of the tumor board. Humans still meet to discuss the case, but a lot of the work is done in the background by these agents. Molecular biology or molecular pathology is another application where I do believe that AI will be transformational. The interpretation of the genomic findings will be dramatically enriched by the knowledge of these models. For humans, it's impossible to keep up with the literature and also understand the relationship between complex genomic changes at different levels, and AI will change this too. So there's a variety of applications. These are still the early days, it's the beginning of transformation, but it's going to be very profound.
AI works very well in research, but what are still the difficulties when trying to really apply it to every day for the care of patients?
Yeah, research is easier than the clinical care. A variety of reasons. Some of them have to do with the sources of the datasets themselves. The clinical care is very disorganized, very very random. Very often you have missing data, or you have datasets which are incomplete or inaccurate because things got missed in the clinical translation. So that's the challenge. You need to harmonize for all those kind of differences in delivery. Actually, I do think I can do pretty well in that particular arena. But also there are other implications that have to do with the treatment of the patients themselves. You want to be sure that the model is reproducible, that it's actually keeping up with the drift of the patient populations. You want to be sure that the models are actually capable of recognizing the diversity of patients' populations, their ethnic diversities, their different genomic backgrounds, so that can impact the way that the AI will be able to deliver answers. And so there's a lot of complexity in the clinical space that needs to be taken care of. In addition, most of the work is often retrospective, but the clinical work needs to be prospective. So any kind of validation needs to be a prospective validation. So a lot of work that needs to be done. I do think it is possible, but it needs to have a specific mindset that is different from the research mindset, and it certainly has a higher burden because ultimately the impact of the patients is can be very dramatic, and so the proof that you need to match is a much higher standard, right? Yeah.